welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson. Today, I am so excited to bridge the gap in women's heart health. Today, our guest is Dr. Regina Druz, and she is not just a cardiologist. She is a trailblazer in the movement towards precision-based, longevity-focused medicine. As the CEO and founder of Holistic Heart Centers, she is redefining heart health through cutting-edge fusion of integrative cardiology, functional medicine, and digital innovation. With a medical degree from Cornell University, board certification in cardiology, and advanced training in functional medicine, Dr. Druz brings scientific depth and systems thinking to every patient encounter. Her proprietary program, Fit in Your Genes, personalizes care through genetic and metabolic profiling, offering clients a transformative roadmap to viability and health span extension. After earning a dual MBA and Master's in Health Policy and Research from Cornell, she went on to lead a value-based cardiology transformation at the national level. Today, she applies that strategic vision to build scalable models of health that are personalized, proactive, and precision-driven. Driven by data, powered by purpose, and rooted in compassion, Dr. Druz helps patients and healthcare systems move beyond risk management towards health optimization. So I hope you'll join me in welcoming Dr. Druz to Menopause Rescue. I really enjoyed this conversation. We took kind of a deep dive into women's cardiovascular health. I am so excited to welcome Dr. Regina Druz to our podcast. Dr. Regina is a leader in cardiovascular health. We're really delighted to focus on cardiovascular health because 1 in 5 women die of heart disease, and more women die of heart disease than of breast cancer, and we are not talking about this enough. So we're just going to dive right in. Dr. Regina, most of my patients are in the menopause transition. And I think a lot of times when we're talking about menopause, we're talking about hot flashes and night sweats and vaginal dryness, but we fail to kind of mention some of the other cardiovascular impacts of having estrogen levels start to fall or even fluctuate. So if you could kind of, from your cardiovascular lens, how are you thinking about women in menopause? What are they experiencing?
Great question, Polly. And actually, thank you for having me. I really appreciate the opportunity. It's interesting that you mentioned, when you said that, more women die of heart disease than of breast cancer. But I think what a lot of women may not be realizing is that the risk factors for breast cancer and for cardiovascular disease actually overlap quite a bit. And so it isn't, I'm just going to prevent breast cancer or I'm just going to prevent heart disease. You need a woman's task is to actually prevent both of these chronic conditions. And luckily, we can focus on risk factors that everyone knows about, but not everyone is doing to mitigate, if you will, so that we understand how women can prepare themselves. And, the traditional cardiovascular risk factors still apply to women regardless of their age. What we are seeing, of course, and that's what the clinical study showed us, is that women, as they begin to approach menopause, right? So that period called perimenopause, maybe a few years before they start to experience experience this 1 year without a menstrual period, that's sort of, a milestone of this final menstrual period on both sides is flanked by different categories of cardiovascular risk. So standard risk factors: high blood pressure, increased BMI, diabetes or prediabetes, dyslipidemia, things that have to do with high cholesterol, cigarette smoking, physical inactivity. These are traditional cardiovascular risk factors.
Mhm.
But what happens during transition from perimenopause, then menopause, then postmenopausal window, is that we see amplification of these cardiovascular risk factors because of the hormonal influences. And very often we begin to see things that you and I know we see it in clinical practice, right? We see weight gain, we see something called central adiposity, which is kind of development of that, abdominal fat or central fat or increased in waist circumference. We begin to see labile or elevated blood pressure, cholesterol abnormalities, and there's some really specific cholesterol abnormalities that we're looking for. And of course, variations in insulin sensitivity and elevations in blood sugar. So this kind of forms a package that in many ways will guide, unfortunately, what happens with women's health in her later years. And, based on at least the research that I'm reading, it is expected or it's known that life expectancy is increasing. So we as women will spend 40% of our lifetime in that, menopause, postmenopause time frame. And so, do we want to spend it as women who are strong and vibrant, or do we want to be, in emergency rooms with hypertensive urgency and, hormones that are all out of whack, right? That's sort of a decision point that we need to make. So that's, focusing on standard conditions, but also understanding what specifically happens in perimenopausal transition, even if a woman didn't have pre-existing conditions, or maybe they were mild. I think those are really key objectives for us in helping our patients to navigate that time frame successfully.
I love what you're saying, and I think I'd like to dive into a little bit more about the cholesterol changes. So, a lot of
Yeah.
women will say, I am so grateful that so many women I'm working with are really engaged on exercise, clean eating, stress management. Like they have got this stuff dialed in. And so they're excellent keepers of their body and they keep track of their labs and they'll say, you know what? My cholesterol just went up by 10, 15, 20 points, and I didn't do anything differently. I'm still at the gym. They're like, I'm doing the work. What's happening? Right.
Right, exactly. So those have been well described. What we do know is that, menopause or menopausal transition is divided into a couple of stages. And, as I mentioned before, we'll look at premenopause and perimenopause, which is maybe within that 5 year time period before the official definition, when the menstrual period disappears for a year. And then after that menstrual period disappears for a year, this postmenopausal stage, it could be obviously some women within the first 5 years, it's early, right? That just happened 5 years ago. And then, of course, we get, women get older and that becomes more of a late, postmenopausal time frame. And so what's happening in these time frames is actually different from stage to stage, but of course it is connected. One of the most troublesome things that emerges in perimenopause and menopause is the cardiometabolic or metabolic syndrome. Now, we typically call it metabolic syndrome because it's short and most people understand what it is. But I think to understand the lipid profiles, one really needs to approach it from the cardiometabolic perspective. And so in cardiology, lipidology, we usually look for something called dyslipidemic triad, right? It sounds very fancy, but I usually describe it to my patients as, a Bermuda triangle that they're trapped in, right? So what are these things? We see elevated atherogenic particles. So typically we will see elevated LDL cholesterol, which is just a cholesterol mass, but we may also see things such as elevated non-HDL cholesterol, and of course, elevated ApoB, right? So this is sort of this big marker. We can think of it as a sum total of all cholesterols that could cause arterial damage. That's what ApoB actually is. So that's sort of like one corner of this Bermuda Triangle. Another one is the emergence or loss of HDL cholesterol and changes in HDL cholesterol function, right? So we know that with menopause, it's not just the HDL number. The HDL, high density lipoprotein cholesterol, for menopausal women has a complex relationship, because some data shows that before menopause, higher HDL levels are associated with cardiovascular protection. After menopause, the relationship may actually reverse. So some women are coming in and say, well, I'm good. My HDL is high. I'm like, and not so fast. So we are seeing alterations in HDL, both quantity, particles, and probably function, although this is not, necessarily easy to measure. Some laboratory tests are alluding to it. HDL particles could be used. So that's sort of another apex of this triangle. And finally, in the kind of the third corner of it, we're looking for things that are spelling out trouble. And typically, of course, high triglycerides will be a clue that this is a cardiometabolic pattern, right? If I have high ApoB, high triglycerides, we're pretty certain that some cardiometabolic influence is taking place. But we're also looking for things such as small dense LDL, which is, or oxidized LDL, which are byproducts of the entirety of this cholesterol metabolism. And when LDL hangs around and those ApoB particles continuously change one into another, this small dense LDL is essentially a really atherogenic, persistent cholesterol particle that is essentially a henchman, right? It does the damage on behalf of LDL cholesterol, right? It's another ApoB particle, and that's essentially what it's doing. So this dyslipidemic triad of high cholesterol, and as you said, you're describing, women are not doing anything different, but they're coming in and all of a sudden their LDL cholesterol is up 30%, sometimes 50%, right? High triglycerides and low HDL, those are telltale signs that the primary problem is now cardiometabolic. And this pattern, of course, persists if no measures are taken. And it goes along for the ride with other things such as blood pressure dysregulation, increased arterial stiffness, loss of so-called endothelial protection, right, as estrogen levels fluctuate. And it is also fed not just, or it feeds itself. So it's sort of like, a circular situation, because we know that just having this lipidemic triad may actually be associated with earlier hormonal changes. So that's one relationship. And we also know that hormonal changes, especially early hormonal changes, premature menopause or early menopause, of course, results in these dyslipidemic changes. So there is a relationship. And the scary part of this relationship is that not only does it contribute to things we know, increased body weight, increased BMI, increased central adiposity, but it also contributes to deposits of fat in the organs. And, liver is one of them. But there is another fat deposit, which is very dangerous for women, and that's actually the heart. So most women do not know that it happens in men also, but women specifically are subject to this during menopausal transitions, is that there are fat deposits in the areas around our heart. In early life, they carry a protective function. But as we get older, especially during these cardiometabolic influences, these fat deposits could become inflamed. So they're secreting cytokines, they're secreting inflammatory agents. And these fat deposits are around the heart, they also surround the heart arteries, and they're actually locally promoting coronary disease, heart failure, stiffness of the heart muscle,
Mhm.
and even atrial fibrillation. So these constellations, and we know clinically, for example, that middle-aged women, especially if they're overweight and obese, postmenopausal, have a much higher incidence of atrial fibrillation than men, right? It's a known fact. It's been known for a while. But I think we finally begin to understand why this may be happening. And the key is that these unhealthy fat deposits, and we call them ectopic adipose tissue, or EAT, are actually influencing, what is happening on a more systemic scale, metabolic. Does this make
So,
sense?
yeah, you've got this triad of the high cholesterol, especially thinking about small LDL, ApoB, dysfunctional HDL cholesterol. So we're sort of questioning, reevaluating the idea if I have an HDL cholesterol of 100, I have nothing to worry about, right? And I think
Well,
that's
yeah,
something
it may not be working. That's why it is 100, right? So the
right.
body is compensating for something.
Yeah, I'm 51. So, like, I went to medical school 25 years ago. And so, this is really a reprogramming of how we were taught, which is so we got to keep updating our knowledge. And then, so I love this triangle. One thing I wanted to ask about is this: as estrogen levels are fluctuating, particularly in the perimenopause, a lot of women are coming in complaining of rapid heart rate. And
Right.
it's often something that's very alarming to them. And one thing that because I'm a gynecologist, I don't have an EKG machine in my office. I don't have a Holter monitor in my office. I'm often sending these things out. What's so frustrating to me is that if someone feels like they're having palpitations or they're having this rapid heart rate, we've got all this wearable tech now. So one would be like, my heart rate is at 120 at rest. And I'm like, okay, thyroid, electrolytes, iron, all the things,
All the
it all
usual
checks
stuff.
out, right? Then
Right.
I feel like, well, we can't just say it's perimenopause. We have to prove that there's nothing else going on, right?
Right.
So, can you kind of walk women through how they can, if they're experiencing this, what was their next step after they've kind of had a basic blood workup, thyroid, electrolytes, making sure they're not anemic, those kind of things. They're having this rapid heart rate at night. What else do they need to be doing? Because it can be so unsettling. And I think
Yes. Yeah.
women deserve a workup, not it's just perimenopause.
Exactly, exactly. So if we look at kind of perimenopause, menopause as a package, right, and we know that these vasomotor symptoms are actually quite common,
Mhm.
one begins to understand that fluctuations in heart rate and blood pressure are part of that package. And I think what women often are missing is that palpitations we can feel, right, but blood pressure, which unless it becomes really high and starts to give people symptoms, is essentially silent. So the one of the things that I always advise women who are experiencing palpitations, and let's say we ruled out the basic culprits as you mentioned, right? They're not anemic, it's not a thyroid, it's not an electrolyte abnormality. We ruled all of these things out. Is to really get a blood pressure monitor and figure out what the blood pressure is at home. Because is it a situation where blood pressure is trending higher? And this is why the overall cardiovascular system is kind of responding to it. And then when blood pressure falls, there could be some irregularity or some accelerated heartbeat just to
Mhm.
kind of maintain what we call cardiac output. What is going on, right? Is it and something related to anxiety and to these hormonal fluctuations, because we know that autonomic nervous system of the heart is very sensitive, especially at night, I would say. And if people are experiencing it at night, things such as heavy meals or even foods that irritate esophagus, because
Mhm.
people forget that esophagus sits right behind the heart. They're actually touching each other. They're like this. And so any irritation in the esophagus could potentially irritate the coverings of the heart, we call it pericardium, enough to actually cause palpitations. And actually, we do have an imaging procedure where we image through esophagus, looking at the area where AFib often arises. It's called left atrium, because again, this is such a close proximity. So, common things include dehydration, exaggerated or late night use of caffeinated beverages, including teas, heavy meals, some sort of anxiety or overall kind of stress provoking experiences that could happen at night. Being hungry, right, and experiencing low blood sugar potentially will trigger palpitations. And it's interesting that you mentioned tech, because right now there are a couple of devices that people may be able to use. So for example, my favorite is actually my Aura ring, because it gives me my heart rate, my recovery, my HRV. I like it. It gives me sort of a good measurement of where I'm heading. Certainly, wristwatches, Apple Watch is one of them, will actually give a 30-second ECG reading, and it will use AI to interpret it for you. And finally, there is this little handheld device. It's by a company called AliveCore. And I'm going to let them know that I mentioned them, although they're not sponsoring your episode. But this little device is called Cardia, and it looks like a little credit card. That's the recent version, and you can literally carry it in your wallet. And all you got to do is to put two fingers on it, and it actually records and interprets the heart rate and the heart rhythm, right? So we're a little bit less concerned about the heart rate if the rhythm is normal. But if the rhythm is not normal, we would be much more concerned. So those are things that, allow, I think, an individual, whether they're a man or a woman, to learn, is there a pattern, right? Because as you mentioned, most of the time we don't find, a cause, systemic cause. And honestly, most of the time we don't find a structural heart cause either. We don't find an arrhythmia. This is part of that package that people experience with perimenopause and menopause. And of course, if these symptoms are ongoing, I would always favor to do at least an echocardiogram of the heart and maybe a monitor at some point to make sure we're not missing anything, that there's no structural heart issues, sort of things are in the clear. And if things are not in the clear, we know how to fix that situation.
Yeah, absolutely. I think when I was younger in my career, I had a patient whose daughter had ovarian cancer. So obviously, the woman was under an enormous amount of stress. And I was listening to her. I'm like, you know what? Yes, I know you're under a lot of stress. You're presenting with a lot of cardiovascular symptoms.
Right.
And her primary care had said, it's just stress. And I'm like, yes. And she still deserves a workup, right? We don't treat men
Of
this
course.
way,
Of
right?
course.
And so we were at different offices. And so I grabbed one of my internal medicine colleagues and I said, I'm really worried about this person. Can I borrow you for 5 minutes? Can you do an EKG? Let's see. And her EKG was abnormal. She
Mm,
had a stress test, made it very few minutes on the stress test, sent to the hospital. She was 98% occluded.
there you go. Yep.
And I'm the gynecologist, right? And
Right.
so I just think we have to keep advocating for women that yes, we may well be stressed out at midlife. We still deserve a workup.
100%. And you know what? We also know that there are, in addition to coronary disease, which is what this patient had, which is, something that we may expect as women get older, we also know that younger women nowadays, because of our imaging techniques, we're able to discern earlier subclinical coronary disease that could become clinical. In addition, there are very specific syndromes that almost exclusively, not 100%, but 90% happen in women, and specifically that have to do with structural heart changes. One of such syndromes is called Takotsubo cardiomyopathy. So it's sort of a very unusual name. It's from a Japanese scientist who described it. He likened it to this vessel that is used for catching octopi. It's sort of like a flask with a narrow entrance and, a big kind of body, if you will, right? So, and this syndrome in cardiology is called apical ballooning, because when we image the heart, this is what we see, that the apex of the heart looks like a balloon and the rest of the heart, its base, looks like it always does. So this apical ballooning or Takotsubo cardiomyopathy, 90+% of these cases are middle-aged women. And it's sort of interesting because it illustrates, talking about changes that happen with menopause, increased anxiety, propensity for depression. Takotsubo is viewed as a two hit hypothesis that the first event is actually not cardiac. Very often, the first event is more emotional or psychological, right? Depression, stress factor, as you mentioned, illness of a family member, some sort of a catastrophe, illness in the body, let's say, women receiving chemotherapy for the first time, processing, the fact that they may have cancer. And so that is sort of the initiating factor that initiates the cascade of neurohormonal changes, inflammatory changes, and the heart follows through and it literally gets stunned. And so, in common language, we call it the broken heart syndrome, because this is what broke this person's heart. And the intriguing part is that it almost always occurs around the middle age when women are perimenopausal or menopausal, and it's almost an exclusive female disease. So we know that these symptoms that women are experiencing, I agree with you 100%. One should not take them and dismiss them, because if it's a healthy person who did not have symptoms before, who haven't had heart issues previously, they merit a workup, right? It's our job to prove that there is nothing serious for this individual, because if there is something serious, we need to fix it, just as it happened with your patient.
Right. So we've talked about some of these newer markers. We've talked about apolipoprotein B. We've talked about small particles of LDL cholesterol. And I think, again, since 25 years ago when I went to medical school, we were just talking about LDL cholesterol. And now we've got LP little a, right? Like, what
Yes.
is the inherited risk that you're bringing to the table? We've got uric acid, we've got homocysteine. We're now doing a lot of coronary artery calcium scores. And so what I'd love for you to do is kind of help people understand, as we're getting more and more data points and we're trying to be really proactive, right? At 50, I am making the heart attack I might have at 70 right now. So
Right.
at 50, we want to really get what's going on. Let's put on our Nancy Drew detective hat. Let's look hard at what's happening. How do we there's no online algorithm to put all of these in like a Framingham risk score, right? And spit out their risk, right? How do we weight all these different markers together? When you're looking at someone's constellation of data, how are you then deciding, okay, this person needs pharmaceutical intervention, this person's safe to keep working on lifestyle? If you could kind of walk us through, I know that's a big ask, but I'd love your expertise.
Of course. So I talk a lot of it on my own podcast, and more is coming. So there actually are online algorithms.
Oh, great.
But the problem is that, I always tell my patients, it's like trying to fit a square peg into the round hole, right? Some of it fits and some of it doesn't. But it gives us at least a baseline. And what's interesting is that the algorithms are actually evolving. Some are generating controversy, some are more established. So specifically what we do at the Holistic Heart Centers is that we obviously do a very in-depth lipid and cardiometabolic profiling, and that of course includes going beyond the standard lipid panels, looking at all the particles and small dense LDL and oxidized LDL, and even the measurements of the vascular inflammation and vascular protection, right? Because they kind of part of the puzzle. We also do a lot of medical grade genetic testing. So not just looking at variabilities in a single gene, but that's called genotyping, but kind of looking at the pathways that are guiding what is happening with lipids and metabolism and predisposition to Alzheimer's, dementia, and various, nutritional components, aligning them in a pathway. And, we don't do this, but, people who develop this technology, they're measuring variable components of these genes, adding these together. And this is known as a polygenic risk score. And that's actually very powerful, because that the abnormalities in the polygenic risk score, or the sort of stratifications in these scores, are important, because more people have many of these different variants than one necessarily big bad gene, right? So currently, there are no online calculators that I know of that incorporate polygenic gene information. There are some calculators, for example, United Kingdom dementia score, which is also very important for women, that will include ApoE information. So some genetics is starting to come in. But if a calcium score is available, one of my favorite calculators is something called MESA, which stands
Yes.
for Multi Ethnic Study of Atherosclerosis, right? And this is a great opportunity because it tells a person, whether it's a woman or a man, what is the implication of not only the lipids and the family history and the blood pressure and medications, but when we focus on the end result of all of this, which is the calcium in the coronary arteries, and that's the only parameter they would let you enter. You cannot enter, soft plaque or anything else. When we focus on the end result, we are able to say, is this person in a much higher risk range than one would expect for their age, gender, sort of like versus the population, right? And if they are, does it really tell us that this is accelerated atherosclerosis? And once it's found, we have to ask ourselves, well, why is it accelerated? What is happening with this individual? Right. So this is, this is very important. There's also something called Reynolds risk score, which was developed by Dr. Paul Ridker. So basically, Reynolds risk score is another opportunity. That was actually developed for women and actually includes high sensitivity C-reactive protein.
Right.
Does not really include a calcium risk score. So these are kind of two things that women can use. A more contemporary estimator is called something called Prevent. So it's a little bit controversial because even though it was obtained from a very large cohort, it basically showed that fewer people may benefit from statins than we
Mhm.
thought based on Framingham risk. But
Right.
an interesting part of Prevent is that it actually allows us to enter certain things which are cardiometabolic and even cardiorenal metabolic, like
Mm-hmm.
albumin ratio, for example, right? Or a microalbuminuria. It also allows us to put in hemoglobin A1C, no homocysteine. We don't have a calculator that does that, or uric acid. And it actually also looks at the social index, right? So by providing a zip code, Prevent aims to actually take into account environmental influences because we know there are significant environmental influences for heart
Sure.
disease, right? The studies just came out, I think, in the European literature that is on my desk to read about how environment negatively influences cardiovascular outcomes. Not new. We've known this for a long time, right?
Right.
We just finally, I think, beginning to unravel it and try to figure out how we can prevent it.
Sure. So I just wanted to kind of clarify a few things. When you say the word renal, you're talking about kidneys. So
Correct.
someone who had, let's say, hypertension, they're going to damage small blood vessels, which is going to show up as kidney disease. And that's why that's one more marker that makes sense to look at cardiovascular health. And
Yes.
then I think we know that particulate pollution. So let's say if I lived in LA and there was a lot of particulate pollution living in a zip code in LA versus if I live in, I don't know, rural North Carolina where
Right.
there's not as much of that, that's going to affect my cardiovascular risk, probably my dementia risk, so many other risks. So,
Absolutely. And I think there's also something called social deprivation index, right? So it's
sure.
not just looking at the particulate matter in the environment and say typical environmental pollutants, but looking at the environment as a whole. Is this a community where there are limited resources, there are difficulties with obtaining, for example, clean food, there is, high crime levels and things of that nature. There's limited community cohesion or connection. So this social deprivation index is also entering the calculus right now for cardiovascular. Some of the communities that have historically experienced that, they call this phenomena weathering, right? So it weathers your body. It makes you older faster because of these influences.
Right. So those socioeconomic determinants of health, systemic racism, chronic stress, all of those things. I'm really glad you tied that home because it is so much more than just is there pollution, right?
Right, right.
Um, I'm glad you brought up MESA. I've been using the MESA score, and one of the reasons why I wanted to reach out to you is that I'm always like, and is this good enough, right? And so at Menopause Society, we talk a lot about women's cardiovascular disease tends to be more microvascular than
Hmm.
large blood vessel disease. And so when I'm like, trying to be a little doctor that could, and I'm putting in my MESA score and I'm getting someone's arterial age, then I go home at night and I think, did I really do a good job today? Because if the calculator I'm using was really looking at men's heart disease and I'm using it to measure women's heart disease, am I giving us a false sense of security if their MESA arterial age is good, but I use the wrong calculator? And I don't know that we have a calculator for microvascular disease, but this is what's keeping me up at night. So I need some help because I want to do my very best job here.
Well, so let's sort of go through the stages of it before we jump to microvascular disease, right? Remember that MESA actually looks at the coronary artery or allows us to input coronary artery calcium, right? And
Mhm.
now coronary artery calcium is the end stage of atherosclerosis, right? It's end stage of the vascular damage. And a lot of young people, even though there is a MESA version for younger individuals, and it still allows us to input coronary artery calcium. So it's not that it's a men's calculator used for women, because everyone was represented in MESA, including different minorities and different genders, but it's only measuring this end stage process that takes decades to develop. We know that for a lot of younger patients, they're not going to have any coronary artery calcium, but they're going to have soft plaques because they're young. So I recently saw, I saw a man and I saw a woman. They were at about the same age range. And both of them, the woman is actually perimenopausal. She's not technically in menopause yet, but in her early 50s. And the man is the same, I think early 50s as well. And in both of those situations, they had high risk plaque, which was non calcified, right?
Mhm.
So, and that brings us to the arena, what do we need to do once we get this number? Is it enough to say, well, that's good. You are in a great place. And I think the answer really depends on, do we really want to go further and personalize our intervention, which is at holistic heart centers, that's our goal, or are we comfortable with just this population based estimate, right? So this is what doctors and patients need to understand. MESA calculator, Prevent, Framingham, Reynolds score, they are population based. They're not looking at a person in front of them. They're spitting out a number that is based on the inputs that were derived from certain populations. And they're trying to gauge, is this person, how do they fit in the population, right? So that's kind of level one. Now, level two is where we go and we start looking for a lot of these issues: soft plaques, high risk plaque, and, as you mentioned, microvascular disease. Now, microvascular disease is it's a difficult entity to find, and it's a very difficult entity to understand. And in cardiology, we recognize something, and again, women tend to be, most represented in this particular disease group, is that we recognize something called NOCA, non-obstructive coronary artery disease, right? And so NOCA, sometimes we have women who have MNOCA, so myocardial infarction, due to non-obstructive coronary artery disease. And I have a patient like this. It's an older patient in my practice who actually has a persistent cardiomyopathy. So it's mild cardiomyopathy, mild weakness of the heart muscle, but she had a impact from this non-obstructive disease. And of course, the purported mechanism is microvascular dysfunction, right? So it's not there was no blockage in the main coronary arteries, we call them epicardial coronary arteries, but for whichever reason, the perfusion, the blood supply to an area of the heart muscle was not adequate. And she ended up with so-called non-transmural myocardial infarct, right? And so that, of course, decreased her heart function. So we can diagnose microvascular disease, and it's challenging using more sophisticated imaging techniques. There are certain imaging techniques that are specifically geared toward microvascular disease because they're able to show us how much blood supply the heart is actually getting in various regions, and is it increasing this blood supply appropriately when we expect it to, because we give an agent that is increasing vasodilation, right, bringing more blood to the heart, at least through the typical arteries that we have. And do we see that the heart is able to supply the muscle with as much as it needs, or is it off? And in essence, that's the definition of microvascular dysfunction. And the problem with microvascular dysfunction is that none of the traditional treatments for epicardial coronary artery disease work well. But guess what works for microvascular dysfunction? And last year I went to a conference because I do a lot of cardiac imaging and I'm still part of Cardiac Imaging Society. So I went to a conference specifically to listen to cardiac imagers to talk about microvascular dysfunction. And hormones work.
Yeah.
Hormones
They
work.
work for so much.
Hormones work for microvascular dysfunction. Now, there are no large randomized studies that I know of, but there are there are some series, there are some case reports, is that hormones work. And I also suspect what's going to work for microvascular dysfunction, and there are studies supporting that actually, are the newer medications that we have right now, right, which is GLP-1s.
Mm-hmm.
Right? Because the GLP-1s are very interesting because we think of them as medications that were initially developed for diabetes, then became approved for weight loss, but they currently have a huge amount of cardiac indications, anything from coronary disease to heart failure. And some of the most recent studies, for example, in more complex patients, have documented that these medications may have a direct vascular effect independent of weight loss.
Right. And they're anti-inflammatory, right? And so
They're anti-inflammatory. And so, you and I are both functional medicine physicians. So, we prefer to go through lifestyle modification first and foremost and forever. But there are definitely situations or times when GLP-1s or related medications will actually be helpful, right? So it all boils down to who is the person in front of you.
this has been so helpful. Maybe we could kind of wrap up
Sure.
with how women can advocate for themselves better in the system, and then also let folks know how they can work with you, because it sounds like you're really honing in on personalizing using genetics at a very in-depth level, and that in a lot of really complicated imaging that I just don't think a lot of our conventional cardiologists are not taking this deep of a dive. So please tell us how folks can work with you and how women can advocate for themselves.
Yeah, so this is a great question. So how women can advocate for themselves. I think it's important and obviously I'm a woman, you're a woman, is that when certain things are not right in your body, right? And as women, we know it. I think most women know and understand when things appear to be not just, casually wrong, but there is a consistent, symptom or sign that something is wrong. Seeking medical attention promptly and asking the right questions is really key. Right. And the right questions are not, jumping to conclusions, but really asking a doctor or whoever is the medical professional evaluating a woman, what does it mean? Is blood pressure 130/80 normal? Should I be monitoring my blood pressure at home? Are the tests that you are doing going to be enough to determine my heart risk? Are there any additional tests? Do I need any other types of studies? Maybe they're not just blood tests, but maybe they're genetics. Maybe there are some sort of a imaging study to really determine my heart risk, right? So there is a lot of the opportunity lies in asking simpler questions. Being your own advocate is absolutely key. Blood pressure cuffs have gotten so great. We use a blood pressure cuff, that I recommend to all patients. One can get it for less than $100. It is a Bluetooth enabled, and it gives us a wealth of information that people simply ignore because, I recently had a woman who was seen in the emergency room. She had hypertensive urgency. Her blood pressure was sky high. They did what they need to do in the emergency room, lowered blood pressure a bit, sent her home with no follow-up, no medications. Well, guess what? Blood pressure is sky high again.
Up again.
Yeah, of course. So that's how this patient came to me, because we need to fix that blood pressure situation. And so the Holistic Heart Centers, to answer your question, is that what we do is that we assess each patient individually. We typically start with a virtual consult. It's only 30 minutes to get an understanding of what are the health issues, how serious those health issues are, how dangerous those health issues are, because this is cardiology, right? So somebody who has a sky high blood pressure cannot, wait 3 months for the lifestyle program. They need medication right
Right.
now. And then we provide them with a personalized plan. And this plan could include advanced biomarkers, including genetics, any cardiac testing that they need. We actually have locally here in New York, we maintain 2 locations where patients, even if they're out of town, when they do come in, we do full vascular scanning. So we scan carotids, including using carotid intima media thickness that we didn't talk about. We do an echocardiogram, which is the ultrasound of the heart. Obviously, electrocardiogram, physical exam. We'll look at the abdominal aorta, a place where many people hide plaque, and even measure at rest something called VO2 max. So we get
Mhm.
this cardiovascular assessment to really kind of tell a person what direction they need to be going, right? Because you can't be running at all directions at once. And that allows us to create a personalized map. These advanced markers, especially pairing markers with genetics, allows us to derive what's called a lipid type. So, the scientific name is it's atherogenic lipid phenotype, but we'll just call it lipid type. And this lipid type is very important because we can tell a woman or a man, well, that much comes from cardiometabolic, that much comes from hormones, that much comes from inflammation, right? That much comes, from heredity, that much may come from toxic exposures. So we are able to make a difference because we guide it by objective data. So to work with us is super easy. We take referrals. Our website is there. There's a big green button called Schedule a Chat, and that starts the workflow. Or patients could just go into a little For Patients tab and register themselves and request a consult. And we're building a peer network of physicians and cardiologists in the community, doctors like yourself, who we can collaborate with, because at the end of the day, it is collaborative patient care.
Absolutely. And I'm really good at hormones, but I need some help with hearts. So I'm so glad to know you and be able to send folks your way. And so it might be possible that folks could go up to New York, get
Yeah,
assessed, and then we could kind of collaborate on the things
exactly.
that, are once they're back in North Carolina, they don't have to keep going back up to New York,
They
right?
don't. And actually, like I said, so we have patients from North Carolina already coming up, to New York. It's not that far.
Right.
And additionally, looking into to build this peer network in North Carolina, identify cardiology groups that could collaborate with us so that patients don't have to travel to New York and can get some of these studies done locally.
Yeah, yeah. Well, after this, maybe I'll shoot you a couple names because I have a couple cardiologists in the area that
Awesome.
might be open. And
Awesome.
I think that, particularly when you're conventionally trained, you just don't know what you don't know until
Correct.
you learn more.
Correct.
I am so glad you were such a great resource and such an
Thank you.
inspiration because we don't have to suffer and we can make the second half of our lives the best half, right?
Exactly, exactly. It's 100% the best half. And I feel like, and I'm definitely going to reach out to you because I have sort of a heart and hormones project in mind. I find that there is a need to bring in hormonal experts, but also lend a heart lens to it
Yeah.
so that we kind of bring it together. And so maybe you'll be open to that, and that would be fun to do.
Yeah, this was so great. Thank you so much for your time. It is such a big
Welcome.
deal to get someone of your caliber to share your knowledge, and we will be shooting folks up to New York and seeing how we can build bridges between the two of our practices. Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.